Hello and welcome to Primary Care with Jeshni. I am Jeshni Alma, an advanced nurse practitioner and the course director at Belmed. In each episode, I'll be chatting with experienced clinicians from across healthcare about the things that we see every day. We'll be sharing their experiences, practical advice, and a few clinical pearls along the way. So wherever you are listening from, I hope you enjoyed this podcast. Let's get started. Today, we are very lucky to have Dr. Varun Kumar. He's an NHS doctor with a special interest in dermatology, and he's been a national speaker on AI in dermatology, the new budding era of AI that we have, and done quite a lot of research, especially in skin of color, an area which is really, under research at the moment, and we seem to see a lot of. His research has really looked at, especially at equality and diversity projects in skin of color, and he's about to tell us a little bit more about himself before I ask him some questions. So, hello, Varun.
Thank you very much, Jeshni, for having me. It's a pleasure to be here. But yeah, so my name is Dr. Varun Kumar. I'm a GP registrar based at Chelsea and Westminster Hospital at the moment. My background is that I've always been passionate about dermatology, right from university up to my postgraduate diploma as well. I've done a lot of research in skin of color, and it's a pet project of mine that's really that I'm really passionate about in terms of advancing education for healthcare clinicians so that we can get the best possible outcomes for our patients.
On that topic, just following on from that, why is it such an important topic, skin of color in dermatology in primary care?
Yeah, so I think the simplest answer to that is that most dermatology doesn't actually start in secondary care dermatology clinics. It starts in primary care. We see 90% of all NHS presentations, and about 15 to 20% of all primary care presentations are dermatology. And we are the first point of contact for eczema, acne, rashes, cellulitis, pigmentation, infections, changing lesions. So if we do not recognize how these conditions present across different skin tones, patients can be undertreated, misdiagnosed, or even diagnosed late. And I think the problem is that a lot of dermatology teaching has historically relied on redness as a main visual cue. And we're taught that eczema is red, cellulitis is red, psoriasis is salmon pink, and drug rashes are all red. But in darker skin, inflammation doesn't show up that way. It may look purple, gray, brown, darker than the surrounding skin, or just sometimes it's very subtly different. And often the better clues are actually not color at all. It's actually those other clues like warmth, swelling, tenderness, itch, scale, um, or the patient just saying, you know what, this is not normal for my skin. So I think that the main thing is just, the key phrase is inflammation is not always red.
That's a very good point, actually. Um, you sort of answered this already, but why do you think clinicians can miss skin problems in darker skin tones? You mentioned about redness, especially.
Yeah, I mean, I don't think it's I don't think it's because as clinicians we're looking to miss these or that we're careless. I think our hearts as clinicians are always in the right place, but I think it's because our pattern recognition has been trained on a very limited image bank. Dermatology is inherently visual. You learn it by seeing it again and again. And if most of the textbook images, teaching slides, and exam resources show lighter skin, then your brain just becomes calibrated to that. I would implore anybody to just Google eczema and see how many search results on Google Images show skin of color. I mean, I was looking at this 2023 study that was essentially looking at AI being trained on medical textbooks to identify skin lesions in skin of color, and it found that actually in those textbooks only 10.5% of all the skin images
Hmm.
were Fitzpatrick type 5 and type 6. And for
Oh,
those of you who don't know, Fitzpatrick is essentially a scale that is used in dermatology to categorize how dark somebody's skin is. So Fitzpatrick type 1 is the fairest, and Fitzpatrick type 6 is the darkest skin tone. So there was very few representation of the darkest skin tone. And for me, that's not just a small gap, that's a major training issue. So when a clinician says, I'm not confident diagnosing rashes in darker skin, I don't think the answer is to shame them. I think the answer is to improve exposure through adequate training. Um, so, with skin of color, we have to consciously, keep retraining our eye.
Um, that is so true. To be honest, I did not know about the scale before until really recently. And I've been in the profession over 30 years, working in primary care. So that's really interesting that we're not even aware that it exists. And historically, if you go into most resources, it just shows you the lighter skin. And I come from an environment where I treat more darker skinned individuals. So how would how would inflammation look on darker skin compared to lighter skin? Because
Yeah,
you don't have that redness as such.
yeah, that's a great question, Jeshni. I think your first shift as a clinician is to stop treating redness as the only sign of inflammation. Redness is useful, but it's not the whole story. So, in darker skin, inflammation may look darker than the surrounding skin. It may look purple, grey, dusky. But what is more often helpful is when you look at other signs, so things like the texture, the temperature, and other kind of surrounding symptoms. So I would be asking myself, okay, is the patient's skin warm or hot? Is it swollen? Is it painful when I'm palpating? Is it itchy? Is there any scale? Is the skin thickened? Are there any signs of excoriation? Um, uh, is there any like cracking, weeping, or crusting? But the most important and fundamental question to ask the patient and to ask yourself is, how does this compare to the patient's normal skin? And that last point is really important because patients know their skin the best. They know their own
So
baseline.
true.
And, a patient may say, this has gone darker, it looks bruised, it feels hot, I feel like the texture's changed. And that you need to be really clinically receptive to. It shouldn't be brushed aside. So, if I was to kind of summarize, what I've said so far, it's in lighter skin, inflammation is quite often red, quite obvious, and in darker skin, it may announce itself through texture, temperature, swelling, symptoms, or just a simple change from the baseline.
You made really good points, especially around lichenified skin. Interestingly, I've had people walk in and say, "Oh, my skin's gone really black and dry," and I've read it, on Google or something that they've researched, and it said, "Oh, this is not a good sign." They think they've got some disease, but they don't understand that this is how inflammation often could present, especially if they've been scratching their skin. So I'm going to come on to a topic which we see a lot of in primary care, and that is eczema.
Yeah, spot on. Yeah, eczema.
And
Um, Eczema is probably one of the best examples to highlight this. I don't know if you've heard of something called the Easy score. It's spelled as EASI. Have you heard of this,
I
Josh?
have I have actually heard of it, but only just recently as well, only because I've been listening to your talks. That's when I've sort of heard about it. I hadn't in my previous training or in previous education sessions that I've been to.
Yeah, so the easy scoring system, it stands for the Eczema Area and Severity Index. And it's a widely common tool that's used in primary care and secondary care to essentially score atopic eczema. And the main features that it looks at
Hmm.
are erythema,
E
thickness,
for erythema. Okay.
excoriation, and lichenification. And it's quite it's been known for many years to be a quite an effective tool for measuring the extent and severity of eczema. But the issue is that one of the domains within this index is erythema. And
Is that what the EZ stands for? Is the different, is it like a mnemonic or,
so the it stands for Eczema Area and Severity Index,
oh,
but the
okay, that makes
main
sense.
domains are erythema, thickness, excoriation, and lichenification.
Lichenification. Okay,
Yeah.
perfect. I've got that.
So erythema, it comes from the Greek word erythros, which means red. And by definition, it is red. But if you were assessing someone with darker skin and you can't see a redness, there is a risk
It's
that you
often the case, yeah.
score their eczema as less severe than what it actually is. And that really, that matters clinically because a patient may have severe itch, broken sleep, excoriations, bleeding, thickened skin, and which can have quite a significant impact on their life. But if a clinician is visually under reading the erythema, they may unconsciously think, oh, you know what, this doesn't look too bad.
Especially if it doesn't look that bright red that you would see on lighter skin, you know.
Exactly. Yeah. And there have been other scoring systems that have been suggested as an amendment. So one of them that was hypothesized was essentially using an index of grayness
Okay.
to
Hmm.
essentially the level of grayness or violaceous hue as a marker of indicating the severity of inflammation. So that could be one thing. I think in terms of just my practical message is obviously don't let the absence of an obvious redness falsely reassure you. Just be aware that it may look gray, purple, brown, hyperpigmented. You might get papular presentation, follicular, thickened, lichenified. And sometimes in terms of the severity, marking the severity of a disease, it's quite often not what it looks like, but how the patient says that it affects their life. When it's affecting their sleep because they're scratching all night, they say that they're bleeding because they're just scratching all the time and their skin is cracking, or they're embarrassed to wear short sleeves. That is not mild disease just because it's not bright red.
My niece had eczema and I know what it's been like sitting up at night with her.
Yeah.
And especially for children, they want to scratch and you're trying to say, don't scratch, it makes it worse.
Yeah.
And quite often one of the biggest problems was it was undertreated because when she presented and being darker skinned, it didn't look as bad as the sleepless night of itching and scratching that we went through. And I think for the future we'll definitely look at a podcast on just eczema. That's quite a big topic. I think we need to spend a significant amount of time in.
And
And
there's a lot of evidence as well in the US. There are some studies which have shown that patients with black skin are more likely to suffer with more severe disease, and particularly because clinicians might not take them as seriously, or the severity or extent of their disease as seriously, which is a tragedy in my opinion. But it just means that we need to put in more effort into upskilling our own training and knowledge in this particular area.
there's a good one you mentioned, when they have that sort of papular eruption, and it just looks like, like goosebumps basically.
Exactly, yeah.
And so you underestimate that actually because it's not red, it doesn't mean it's not inflamed in a way, or how severe it's for the patient, because you think that doesn't look as red, erythematous and angry when someone with lighter skin has been scratching on it. I'm going to move on to another topic, because we have the
Yeah,
longer study days to discuss this in more depth. And I'm going to talk about cellulitis because that's something else we see a lot, especially in primary care.
of course.
And what does that look? Especially, we see it as red, hot, swollen, and painful. Again, the word red. How would that look?
Yeah, I mean, you're absolutely spot on, Jeshni. Cellulitis is that classic trap. We're all taught that same idiom, which is, red, hot, swollen, painful. And I think it is useful in general to keep it in your mind. But obviously, with darker skin, that red part is much less obvious. And now NHS guidance has been updated to explicitly say that cellulitis makes the skin painful, hot, and swollen, but that redness specifically is less obvious on brown and black skin, which I think is a brilliant step forward. because that ensures that clinicians are aware of what they may be missing with patients with darker skin. And also the British Association of Dermatologists has also described cellulitis as painful, swollen, firm, and hot, but purple or darker in brown or black skin.
That's a good point, actually, especially emphasizing the painful, swollen, and hot. It doesn't have to look red.
Exactly. And I
Yeah.
also think if you're a clinician as well, it's really important to compare with the other limb because cellulitis is majority of the time unilateral. And it's really important to compare with the other limb. If one leg is warm, swollen, tender, shiny, and painful, obviously the safety issue is that if clinicians are waiting for this bright red um,
Yeah.
redness to appear, that you may
It's what we are
diagnose the
taught,
patient
isn't it?
late. Yeah, exactly.
It's what we are taught is to always look for that bright redness, and actually, you know, that doesn't happen. Especially, I'm gonna cover a few other just quick topics, and we will have a series with this all in more detail. But um, another very common thing we see a lot of is acne, and what conditions are commonly underestimated or missed in skin of color in regards to acne? Does
Yeah, I think acne is a massive one, and it's not because clinicians miss acne itself, but I think it's because we underestimate the pigmentation and the burden that leaves behind on the patient. Um, you know, in darker skin, the skin lesion may settle, but the pigmentation can last for months. So the patient isn't just dealing with the active inflammation from the acne, they're dealing with the footprint for every inflamed lesion. The way I like to liken it is inflammation is essentially the fire, but pigmentation or that post-inflammatory pigmentation is that long-term smoke damage that you get as a result of the fire. And you can put the fire out, but the smoke damage still remains. And this is what post-inflammatory hyperpigmentation feels like for most patients. Um, and it can really significantly impact their patient's confidence, their relationships, works, clothing choices, their self-esteem. And sometimes this can be where we as clinicians, we may accidentally minimize the problem. We might categorize the acne as mild because there aren't many active pustules, but the patient is thinking, oh, every spot I have, leaves a mark for
yeah.
6 months. So,
And especially it's in younger people, and isn't it? It's in those teenage years when our hormones are all over the place, and that's a time you're really sensitive about how you appear, and you've got
exactly.
all this pigmented lesions. And from experience, I know it takes a very long time to get rid of it, because one of the problems is then you sometimes use too abrasive products, and you actually cause further damage to your skin.
Yeah,
So
that's spot on. A lot of the treatment is about, more prevention, using tinted sunscreen to reduce post-inflammatory hyperpigmentation happening any further than what has already taken place.
okay, so just two last questions. So, what are the common myths we have about darker skin tones in dermatology?
Um, I think that the first main myth is what I've been going on and on about
What
really
erythema,
during this
redness?
is that, yeah, darker skin,
Yeah,
a lot of people think darker skin doesn't get inflamed. It does get inflamed, but it just doesn't look bright red.
looks different.
Yeah, exactly. And a lot of people think if it's not red, it's not severe, but that's completely unsafe. The second is that, people with darker skin do not get skin cancer and that they don't need to wear sunscreen. The
That is
truth
so
is
not
that
true.
they can. It's a lot less common, correct, than with patients with lighter skin. But that lower incidence can create lower suspicion. And also, statistics have showed that patients with darker skin who have skin cancer can sometimes have more aggressive forms of the cancer because they present later and they're underdiagnosed or misdiagnosed. So it's really important to pay attention and take patients seriously if they spot changing lesions, particularly on the palms, soles, the nails, and mucosal sites. Um, and it shouldn't be dismissed just because the patient has darker skin. So yeah, I would say these are my main myths that need to be dispelled.
That's so true about darker skin thinking. I have seen cases which was quite surprising, cancer in darker skin, and I've looked at the research, which actually does say it's not as often we get it, but we do get it. And also this thing about wearing sunblock, uh, I think it will be quite interesting to possibly do a session on sunblock, and a bit of advice on the creams and emollients, which we'll do at another session. But just as a final point, what changes as practitioners can we make in the way we assess skin in individuals with darker skin color?
Yeah, so I think if I was to give practical, immediate changes that we can do, it would be a 5 point kind of checklist. So for any rash, you want to check, is it raised, warm, swollen, tender, itchy, scaly, thickened, crusted, any change from the original baseline? The second thing I think we all need to do is always compare with unaffected skin because those subtle changes that we
That's
struggle
a
to
good point.
see, it's a lot easier to appreciate them when you're looking side by side. The third is listen to your patient. Ask the patient what they see because they often recognize color and texture changes before we even do. The fourth is, always ensure that you're describing the morphology rather than just relying on the color. So say what you see. Papules, do you see plaques, scale, excoriation? Just mention everything that you see.
That's a good
Um,
point. Yeah.
and I think fifth, and my final point is most importantly, educate yourself, expose yourself to images of dermatological conditions on various different skin tones, because our pattern recognition only improves if we train it. I make every effort I can in all my slides to include, if I'm talking about a particular dermatological condition, to include images of a patient with white Caucasian skin, but also with darker skin as well, as I believe in, equality and diversity in the quality of education that we train our future clinicians with.
Thank you, Varun. That was really interesting. And I know that you're going to do a full day workshop on skin in October, and I'll put that in the show notes. But you've made some really good points, and I really like your 5 points, especially about comparing, describing properly, because clinicians often say to us, "Oh, I hate seeing skin rashes. I never know. Um, I'm always scared I'm going to get it wrong." But I always say, just start by describing what you see. Take a good history to start with. Listen to the patient and what is the patient telling you, in terms of what medication they're taking, what have they applied and tried over the counter, what someone has given to them, especially. Um, and then describe what you're seeing. We often don't have to diagnose, but we have to make it a good description. And that, especially when we're doing referrals or discussing with colleagues, I think that's really helpful. Any final point? I know we've already got your 5 points, but
No,
anything?
I think that's absolutely spot on. I would mirror what you're saying because especially when we're referring to secondary care, it just means that if you're speaking to you're referring to the consultant, they take you a lot more seriously when they know that you can describe exactly what you're seeing.
Thank you very much. And that is so true. Is in terms of our patients with skin with color, is really description and history taking. So Varun, thank you. We look forward to your next podcast where I know you're going to talk about eczema because that's a big subject. So the next time we meet, we'll be talking about that. And thank you very much and goodbye, everyone.
Thanks, Jeshni.